Politicians prove healthcare reform is no easy task. So we asked the people who live and breathe medicine every day. This morning, what would doctors do? And as we mark 50 years since the summer of '67, is Detroit making the same mistakes now that led to such unrest then? Today is Sunday, July 30th, 2017, and this is Flashpoint. Hi, welcome to Flashpoint. It is the last Sunday in July. We're smack in the middle of the hot days of summer, as it was 50 years ago when the fumes that had been building up for years finally ignited. The last few weeks have been filled with the oral histories of those who lived through that summer of '67 in Detroit, but I've been curious about the story going out to the rest of the world. This past week it was a big red carpet premiere at the Fox Theater for Kathryn Bigelow's new, very tough, very violent film, Detroit, which hits theaters nationwide this coming weekend. There was also a column in the Washington Post written by a professor at U of M that suggested Detroit is making some of the same mistakes today that led to all of that trouble. The author of that column, Dr. Heather Ann Thompson, will be here a little later on to talk about that. But we're going to start with health care. Remember health care? It was the centerpiece on Capitol Hill this week, though it was at times very difficult to see through the fog of a mind-boggling presidential address to the Boy Scouts, an assault by the president on his own attorney general, military policy on the transgendered issued via Twitter, and then a vulgar, unrepeatable attack by the new communications director on two of his White House workmates, one of whom was gone a day later. I'm pushing all of that political foliage out of the way to create a clearing for health care this morning. That's because as I've watched this debate play out for months, it's dawned on me that there's been a voice missing from the conversation. Hardly anyone is asking doctors what they think. How would doctors cure this problem? We'll ask them this morning on Flashpoint. Well, no matter how you felt about the outcome, you have to admit there was a certain epic poetry in a man fighting brain cancer returning to the Senate to cast the deciding vote on health care. But with the failure of the repeal of the ACA in the wee small hours of Friday morning, are we standing pat or beginning a new journey toward creating a better American healthcare system? I want to talk about that this morning with a group that seems to me has been largely ignored these last few months. Let's bring in the doctors. Very good to have with me this morning Dr. Herman Gray, former head of DMC Children's Hospital. Dr. Shauna Diggs is here, a dermatologist in private practice, also, as you no doubt know, a regent at the University of Michigan. Our health reporter, Dr. Frank McGeorge, is an emergency room physician at Henry Ford Hospital in Detroit. And Dr. Michael Stellini back with us again from the Wayne State School of Medicine. He specializes in medical ethics, which is also a piece that I think has been kind of missing from the conversation. But Dr. Gray, let me start with you, because the last time you were on the program, it was our conversation afterwards that made me think, yeah, I really need to get doctors to weigh in. It does feel, am I missing it, or have doctors kind of been ignored through this conversation?
Well, I think doctors and patients have been ignored in the conversation.
The other part of it.
They go together, by the way. And, you know, there's been lots of conversation about the political wins or losses, how much money it costs, the ideology of whether or not the government should even be involved in health care, and precious little about what's in the best interest of the American people, and particularly the American people who are vulnerable and most dependent upon these federal programs. And so I think it's really critical to get those who are most impacted by it, involved in this.
Dr. Diggs, it seems to me that there's a measure among some people thinking, well, doctors are going to be fine no matter what the system is. You all make a lot of money. That maybe we don't need your opinion because at the very least, yours is maybe one that's dominated too much by self-interest in this.
Well, Devin, I'm a physician in private practice, so it's really a small business. And I'm I'm on the ground talking to patients all day long, and I hear their concerns. And I'm also running my business. I have people who work for me. I buy healthcare myself. I'm a patient. So in many ways, I understand things from many different sides. And so I think that doctors are really not the ones in this entire situation that are gaining. We're really losing because our patients are losing ground. We're losing ground. The instability in the marketplace makes it difficult as a small business owner to decide who to hire, who not to hire.
Because you don't know.
What computer systems to buy, all these things.
You don't know where it's really headed.
Yeah.
Dr. McGeorge, you and I have talked quite a bit before off the air, as you and I are wont to do around here. This is never the healthcare system that anybody would have set out to design. We improvised our way here, but now we seem unable to create a newer, better mousetrap.
Well, you know, part of the problem is historically, over the last, 50 plus years, America has been unable to, I think, define or articulate goals that we can use to define the healthcare system. In other words, is healthcare a right? Is it a privilege? Should it be a public good? Is it something like, roads, emergency services, or is this a commodity that we should be buying and selling? And until we settle that fundamental debate and really answer the questions there, we can't really design a system that's going to work well, because right now we're just cobbling it together from little bits where, yeah, it sort of is a public good, to little bits of, yeah, it sort of is a commodity. And that's, I think, part of the fundamental problem.
We're really stuck on the building blocks of this. Dr. Stellini, though, it's always seemed to me that once we decided that anybody who shows up in an emergency room is supposed to be treated and cared for, weren't we deciding then that this is a right that people are due?
Well, that's the fundamental question, is it a right? And you talk about ethics and versus morality, and so morals are really a set of values that individuals, groups, societies establish. And the problem we have right now is that more than half of our legislatures and more than half of our people in the country perhaps haven't bought into the idea that access to health care is a right for everyone. That should be a moral value that our society has. If we'd established that, then we would just make sure this happens. But people who are voting against the access that was increased under the Affordable Care Act, whether it was the best way to do it or not, they're really saying it's okay if people don't have access to health care. As a clinician, my practice now involves end-of-life care and palliative medicine, and I pull my last 2 hairs out when I get a 30 or 40-year-old woman who has cervical cancer, a preventable disease through screening and vaccination. Now, a lot of social issues go into why people get cervical cancer, but a lot of it is people don't get the entree into health care with easy access because it's paid for. They're not educated. They don't get preventive care. So it just drives me crazy that people die of a preventable disease like that, a horrible disease. Yeah. When if our system was structured better, I think we would see a lot less of that.
This will be tough for each of you, but let me, if you could invent your own system, if you were starting from scratch, what would it look like, Dr. Gray?
And if there were no politics, so in perhaps an ideal world, we have an economy that obviously is dependent upon business and capitalism, and so I'm not an anti-insurance guy. Indeed, I worked for an insurance company at one point in time, but a system that is simple for doctors to interface with and simple for patients to understand how to get into that system, a single payer system as it were, I think makes the most sense. And for those who—
Universal care like the rest of the world.
Universal care like the rest of the world. And for those who want perhaps more sort of VIP level care, then they can pay for perhaps what might be considered additional things. Maybe that's dermatology, maybe that's plastic surgery, maybe. But that everyone should have the ability to stay alive and healthy by virtue of being an American. I think that Dr. Stellini is right on, that this is a moral imperative. We have long passed the point where healthcare is, sort of, optional sort of thing that maybe these people can have and those people don't have. And it's fundamentally there's, gross inequity in this country because, of course, it's the poor people who it's really okay for them not to have health care, or those who are disadvantaged. And that's just not acceptable to me. That is not consistent with our American values.
Dr. McGeorge, in fact, you working in the emergency room at Henry Ford, a city hospital, you see so many people who are there. You're their primary care physician.
Right. That's exactly it. And I think part of what Dr. Gray is getting at is really critical, and that's that if we don't design a system where there is a fundamental safety net for everyone, we are going to have people that come to, in this case, emergency departments, seeking care at the last minute. We're going to end up spending more resources on care that really could have been, essentially prevented. People would have had better outcomes to begin with, would be healthier overall, and we would be ahead of the game. Instead, we continue to play catch up because we have these gaping holes in the system. And that's really, I think, again, that sort of fundamental question of what baseline do we want to set. And over the last, 50, 60 years in medicine, we have gradually moved to creating a better safety net, but it still has enormous holes, and until we close them, we're in trouble.
Your view of this, Dr. Diggs, is interesting. In your private practice, but in dermatology, I'm assuming you've got a number of procedures that people are bringing you covered by insurance, and then you got a lot that isn't. That is. So your thought on this sort of new world, if we were talking about universal care, what would that mean to you?
I think we have decided that we do want a basic health care for all, because the Public Health Service, right? We agree that children should have immunizations and that we will pay for them out of our taxpayer dollars. So we've agreed on the base. I think we're trying to decide what that next step will be. What level of care? Is it just emergent? Is it basic health care? In my practice as a dermatologist, I have patients who I provide their basic care for dermatology, it's insurance covered, and then I have that next level that you speak of that people want and they pay for themselves.
Botox, or whatever it might be.
Exactly,
Yeah,
and that mix also helps me as a business person, because it's difficult in solo practice to be just providing the basic care.
All right, we'll take a quick break. We're going to continue with this conversation. This is Flashpoint, talking about American health care. Back with more in just a minute. All right, welcome back. We're talking about health care this morning. Dr. Cellini, you made an interesting point to me before the program. A lot of people seem to have an innate, as Dr. Gray was talking about, when politics get in it, there's almost a snap reaction to, I don't want government health care. To your tallying, the government is already paying for more health care than it isn't.
Right. I mean, the idea that this is a government takeover is really a fallacy. If you look at who's getting health care now between the veterans and the military and Medicare and Medicaid,
Members of Congress.
Members of Congress. Well over half people in this country get their care paid for by a government agency. And the Affordable Care Act and most proposals about single payer doesn't propose that the government runs the health care, they pay for it. So in multiple places that I practice, I've run into people with various kinds of insurance. And I can tell you that private insurance companies regulate and dictate way more than Medicare does. And so Medicare for all is a mantra that some people have that are in favor of single payer. Medicare has the lowest overhead of any insurance company. There's no profit to be gained. They're pretty efficient when it comes to administering the payment of health care. So the fact, number one, that the government entities already pay for the majority of healthcare in this country sort of blows the wind out of the argument of this is a government takeover.
And it takes us to cost, Frank, and all of the efforts going all the way back to the ACA and all of what we've watched for the last 7 to 8 years since then, nobody seems to be able to really get a handle on cost, which is the real problem. Right. And yet we look at other countries who've gone to other things and they spend far less than we do on healthcare.
Well, you know, if you look at how much healthcare costs in America in terms of our gross domestic product, if we don't get a handle on it, it will continue to get out of control and become uncontrollable eventually. So, you know, deciding who's going to get healthcare, how we need to provide that healthcare, and then reining in the cost of that healthcare is going to be important. But nobody wants to give up what they have. Pharmaceutical companies, hospitals, physicians, nobody wants to give up anything in that. So until we have those broader discussions about what everyone should reasonably be given as part of the cost, I don't think we're going to come to any kind of agreement. And those are some of the more complex arguments that really have to be brought into the public.
This is a tricky part of it, whether we're talking about Medicaid, whoever, private insurance. We all want Cadillac coverage. We all want the extent that medicine can bring us to keep us healthy and moving along, right?
Yeah, but I would argue that the system that we have currently is disjointed and dysfunctional, and really, you know, using the word system is charitable. You know, Medicare is more of a system than our private health insurance industry is. You have dozens and dozens and dozens and dozens of insurance companies. Each has their own rules in terms of what they cover. Each has their own formulary for which drugs they cover. Each has a different form that you need to fill out to get reimbursed. That if you streamlined the system and made it more efficient and more effective, I would argue that a lot of that cost would disappear, and it wouldn't necessarily take dollars out of the pockets of private practicing physicians or maybe even pharmaceutical companies, although pharmaceutical companies is, you know, something that, you know, should be looked at closely because we also pay more for our drugs than any other country.
What are your thoughts?
I do think, though, that the public can understand these issues, and so if we really had a good conversation, we could get past that. So as an example, if I tell a patient I have 2 creams I can give you, this one's $800 per an ounce, this one's $200 per an ounce, you'd be surprised at how many people will pick the 200. They understand that that difference really isn't worth it, especially if I say, I don't know if that difference is worth it, and they take the one that's more reasonable. So I think people understand that they don't want to add to the cost of health care, at least on a personal level. So if we could talk about it with patients, physicians, insurance companies, hospitals, and really sit down and go through the issues, we could come to some agreements, I think, at least some basic principle agreements.
But how often do we really have that conversation? I mean, I know in the emergency department, when someone comes in and they want care, I check a bunch of boxes and order what I think is necessary, but I don't necessarily talk to the patient all the time and say, well, you know, we could order this CAT scan now and it's going to cost you a couple $100, or, you know, maybe we could wait another week and see how you feel. And more often than not, I just check that box.
Well, Dr. Salini, to you, with you doing end-of-life care, this comes up in a very different, very acute way. How much do we do when somebody is reaching the end, right?
Right, and so you mentioned the word death panel earlier off camera, I believe.
Yes, yes.
And so I want to put it out there that we don't have death panels. No. And there is a big push now, and you heard the word palliative care and the life care. The idea is to do the right thing at the right time for folks. And sometimes we do things, we're driven because we can do them. And it's another place where we could get smart. And sometimes we shouldn't do things, and that won't necessarily lead to more harm or shorter life. We have to think more smartly about it. You've
given us all a lot to think about. Great start on what I hope will be a long-running conversation. Certainly will be on this program. Thank you all very much for being here.
Thank you.
We come back 50 years ago, the summer of '67. Are we heading in that direction again in any way? This is Flashpoint on Local 4.
No game.
Welcome back. We've talked at length about the events of 50 years ago in the summer of '67, about the struggle over finding the best way to mark the moment. We've talked about the sensitivities over what to call it. But this morning, we look ahead. A recent column in the Washington Post held the jarring headline, "The New Detroit's Fatal Flaw." The author of that piece, Dr. Heather Ann Thompson, argues we may be making some of the same mistakes that led to that combustible summer. Dr. Thompson won a Pulitzer Prize for her book, Blood in the Water on the Attica Prison Uprising, also wrote a book called Who's Detroit, and teaches now at the University of Michigan. Dr. Thompson, thank you very much for coming.
Great to be here.
What's been the reaction to, because you live in Detroit, by the way, you teach in Ann Arbor, but you live over here. What's been the reaction to your column so far from the folks that you spend every day with?
Well, I think the column is disturbing to boosters, because I think the idea is that we're doing things completely differently today, and that Detroit is going to rebound effortlessly, at least if we keep the goodwill. But I think for longtime residents, it really rings true to them that this is a familiar story of a city on the move, prosperous, things look great, but it's really ignoring the fact that so many Detroiters are still really suffering, and that's not where the energy or the development dollars seem to be going.
Well, and you also draw in your piece that we can't help but see it as racial, that whites are moving in, whites are buying a lot of things, and a lot of black Detroiters are not.
Right, and indeed that's the way we mark the sign of a returning city often, certainly in the media, right? That the whiter the city is, the more it's on the move, the more it must be coming back. And I think that that's been actually a marketing tool in some respects in the city of Detroit. Again, the problem is this is very familiar. For longtime Detroiters, in 1967, on the eve of the rebellion, it could have been now. The city was booming. It was the apple of Washington's eye. It was a very, very optimistic moment for developers, for everybody, and yet under the surface there was a lot of poverty, a lot of want, a lot of problems that no one wanted to address.
We forget Detroit was making a bid to be an Olympic city at the time, even back then. But I think that some would take issue with the effort. The mayor, and I hate to keep bringing up on this program, the mayor's speech up at Mackinac this year, but it was all about trying to be mindful of that history and trying not to make those same mistakes. Creating new housing where 20% of it is by proclamation has to be low-income housing, that there is all of this effort going into not making those mistakes, but you're not seeing it.
Well, I think that's absolutely right, and I think one of the things that does hearten me, certainly as a local resident, but also as a historian, is that these efforts are being made. Politicians are very aware that any stable city has to be a city that's prosperous for everybody. So that's the good news. My concern, though, is that even the best-hearted politicians face development dollar issues. I know that there's already controversy about maintaining that 20% affordable housing mark in certain of the developments, or where those 20% are going to be located, right? And so it isn't just housing, that's a part of it. It's also, of course, transportation, it's schooling. You know, people often think about Detroit like it's a blank slate, it's an empty landscape where anyone can come in and make it whatever they want.
Not a particularly respectful position, is
well,
it?
there's still almost 750,000 or more people that live here, and so that's what we have to work with.
Well, I think some would say, though, that what's the option to not succeed? Because for years we had a city that I guess you would argue was more equitable, but it wasn't particularly successful. There was no tax revenue coming in, there were no services. At least now, when a new building goes up downtown and new people go in there to work, there's a tax base being created that then turns on lights somewhere in a neighborhood far away.
Absolutely. And so my position as a historian is not that development is inherently bad or that building the city up in new ways is bad. Not at all. It's simply to say that one of the wonderful things about hindsight, one of the wonderful things about history is that we get the opportunity to do it right this time, which is not to say it's all or nothing, either no development or development unchecked. It means that we have to be thoughtful about it. And I think you're right. I think politicians are very much trying to do that. We're trying to imagine the way to do that, but it's always, it's there. We have to be very, very cognizant of it.
That's what I was going to ask then. What is the way to do it without, while we completely understand that business drives so much and that the market and people's choices, that all of these things come into play, how do we then manage it?
Well, I think one of the ways that we do it is that we begin with the proposition that there is always profit, there is always the development dollar that we have to think about, but there's also the public good. And who contributes to that public good? What percentage of our taxes go to the public good? What percentage of development dollars go to the public good? Even if in the short run that might make a mar or a little bit of a dent into a profit, for example, if the long-term outcome is a stable society, then it's worth it. And that's what we learned from '67. What we learn is that the costs of not taking care of all citizens, making them all part of that rebirth through good schools, through good jobs, and through good housing, if we fail to do that, our stability is limited, right? Our growth is limited. Everything is limited by that. So it's really this kind of focus on the common good, which is not pie in the sky rhetoric. It can translate into real development and real planning policies.
If you want to read Dr. Thompson's piece that was in the Washington Post, I guess a week and a half ago now, we will put that a link to that on clickondetroit.com.
Great.
Thank you very much for being here this
morning. Thanks so much for having me.
Thank you for being here as well. Meet the Press is coming up next, right after Mitch Albom's Heart of Detroit. Hope you have a great week. We'll see you next time right back here for Flashpoint.